And if you go to the classical teaching of IBS, the diagnosis is predominantly symptom based, and there is no diagnostic marker available so far, and there is no specific laboratory or imaging tests available, and most of the times it's a diagnosis by exclusion. And there are so many criteria available for the diagnosis of irritable bowel syndrome. The latest one, that is Rome 3 criteria, which came into vogue in the year 2006. For its publication, it was validated in 2 clear-cut studies in the form of a questionnaire. It has got a sensitivity of 71% and a specificity of 88%. And when dealing with the case of IBS and when investigating, one must be cautious about the alarm signs or symptoms. And for the alarm symptoms that are common: age more than 50, unintentional weight loss, family history of GI malignancy, severe unrelenting large volume diarrhea, fever, chills, recent travel to endemic zones, nocturnal symptoms, hematochezia, and relevant findings on physical examination such as arthritis, skin lesions, lymphadenopathy, and abdominal mass. Presence of red flag signs indicate the need for further evaluation and diagnostic workup. The patients with symptoms of red flags, they need not be excluded from the diagnosis of IBS, because IBS patients report presence of at least 1.65 red flag symptoms, and out of these, nocturnal symptoms and onset over the age 50, they are the most common alarming signs. So once the patient has got alarming signs, it need not be excluded from the diagnosis of IBS. And basically it is a diagnosis of exclusion. And my question is whether most of the times patient will come with a battery of investigations, whether it is the anxiety of the patient or anxiety of the treating physician. Were these investigations are really necessary, and are we justified in doing all these investigations? And most of the times they will be doing blood tests, stool examination, lateral breath test, abdominal imaging, and colonoscopy. And always there will be some degree of symptom overlap with organic disease like thyroid disease, celiac disease, IBD, microscopic colitis, lactose intolerance, small intestinal bacterial overgrowth, colorectal cancer. In the absence of alarming symptoms, there may be some value in performing limited number of investigations to exclude organic disease. And now I will come one by one, whatever the literature says, whatever evidence we have in investigating such cases. And the role of, if you go to take the case of lower GI investigations like colonoscopy, in the literature there are total 5 studies, and of the 3 studies they have taken 600 patients. These 3 studies they have taken total colonoscopy alone or sigmoidoscopy plus enema, and one study they have taken 306 patients. In this study they have taken age more than 50 years, total colonoscopy, age less than 50 years, flexible sigmoidoscopy, and one more study they have taken flexible sigmoidoscopy with routine rectal biopsy. Out of these 5 studies, if you take the 3 studies, 600 patients, the yield is only 7.